Very good evening, guys. Very good evening. How are you all? How is your preparation going on? This is the peak time, near your exam. So I hope you are all doing well and you're all preparing well. And most important, this is a time period where you have to maintain your mental balance. That's the most important. There's nothing more to read. You have read a lot. You have to just stay calm. So this last month, try focusing on only on how to stay balanced and calm and composed. So those who are able to stay calm and composed at this point of time are the one who can crack it. There's no more reading which you have to do. You have read fair enough. Believe in it. You have read fair enough. Don't read anything new. Whatever you have read, keep revising that. Solve more and more GTs. It is fine if you're not doing great in the GT. Try to improve at least 10 marks each GT. So at least do 1 week once or 2 weeks may एक GT, so that you will get that accommodation of 3 hours concentrating and how to solve MCQs, and you'll learn how not to do silly mistakes. Silly mistakes is the most dangerous in your exam, guys. Because one silly mistake can afford thousands of rank, and you cannot afford that. So have a great control while you're solving the MCQs. Very good evening, Priyansh. Very good evening, Ganesh. So this is a doubt solving session. Very good evening, Manoj. So this is a doubt solving session. So if you have any doubts, put forward. I will clarify it. But till I receive doubts from you all, what I will be doing is I'll be trying to solve some MCQs along with you. It's been a long time I've not solved MCQs. I've not done a MCQ practice session to you all. So I planned some MCQs for you all in this session. Okay? So I want all of you to actively participate in this MCQ session. So let's see the first question. Let's see the first question. Identify the wrong statement regarding the contraceptive given. Identify the wrong statement regarding the given contraceptive device. So first and foremost, who can tell me what is the contraceptive which you're seeing in this picture? So what is the contraceptive which you're seeing in this picture? So it has copper on its limb as well as it has copper on its arms. So what is this contraceptive? So this is a copper T380A. So copper T380A. So why are we calling this as copper T380A? Because the copper is present on its stem as well as the copper is present around its arms. So when arms are also covered with copper, you call it as copper T380A. Very good, excellent. Guys, I see you are all answering correct. So this is given absolutely free by the Indian government. This is given absolutely free by the Indian government, and this is called as Freedom 10. So if you put this Azadi for 10 saal from bacche, there's no bacha for 10 years, right? So lifespan is 10 years is absolutely correct. So first statement is correct. So lifespan is 10 years is absolutely correct. This tail contains barium sulfate, guys. So that makes it radio opaque. Yes. So as it contains barium sulfate, it makes radio opaque is also correct. What is the most common side effect of contraceptive device? Is it pain or is it bleeding? So the most common side effect is not the pain. The most common side effect is bleeding. The most common side effect of IUCD is bleeding. So this statement is wrong. C statement is wrong. And why do we have increased bleeding with copper releasing IUCDs is they create a state of inflammation inside the endometrium. And that inflammation increases the vascularity. And that is why we'll have more bleeding in these patients who have IUCD inserted. So the most common symptom is, most common side effect is excess bleeding. And the most common reason for removal, most common reason for removal is pain, is pain. So the most common side effect is bleeding, whereas the most common reason for removal is the pain. So option C is incorrect. It is associated with higher expulsion rate as compared to medicated IUCD. Yes, copper releasing are associated with more expulsion compared to medicated IUCDs like Mirena, which releases levonorgestrel. So they have asked what is the wrong statement. So that is why our answer will go for C. That's why our answer will go for C. So lifespan is 10 years. It contains barium sulfate to make it radio opaque. The most common side effect is bleeding and is associated with higher expulsion rate as compared to medicated IUCDs. Okay. There's also one more copper tea which is given free by the Indian government. What is that? So that is Freedom 5. So Freedom 5 is copper T375, which is effective for 5 years. Which is effective for 5 years. Let us see the next question. We'll try to solve more MCQs in this session. A 32-year-old Gravida 2 Para 1 has been transferred from a midwifery-led unit for lack of progress in labor at 4 centimeters. Her previous baby weighed 3.1 grams and was a normal delivery at 38 weeks. Very good. On admission, her observations are normal and the CTG was reassuring. The midwife who examined her has a diagnosis of a complete breech. And they've also confirmed this on her scan. So, Pehla was vaginal delivery, normal vaginal delivery. Now she has breech, that too complete breech. The woman is very keen to have a vaginal delivery. Okay. And decision has been taken to allow her to continue. After 2 hours, there is no progress in the labor and CTG has become suspicious. So what is the most appropriate action? See, nowadays you get to see such kind of questions where you have a clinical scenario and they're asking your opinion ki what do you want to do in this patient. So this is another set of questions which we can tend to see. See, one type of questions are these where you get an image and options. One other type is this where you get a case scenario and you have to answer based on what you would do. So already breech vaginal delivery karna is very difficult because there are so many complications. And in breech we have the rules that never push and pull, no kicham kicha, hai na? And hands off till umbilicus. So don't rush and pull the baby and all because head can get stuck inside. This baby, this labor is stuck at 4 centimeters and it's been stuck almost for 2 hours. Now what do you want to do best for the breech? Very good, Ganesh. Excellent. So whenever you have breech, see breech may, you all know that conducting assisted vaginal breech delivery is not very simple. So you always have the risk of baby's head being stuck inside. So you should have less drama when you're doing assisted vaginal breech delivery. अगर labor अच्छे से नहीं जा रहा है, तो go for cesarean section. Go for cesarean section. There's nothing wrong in going for cesarean section. You cannot do ECV because she's already 4 centimeters dilated. You have already observed for a long time. She's been referred and now you have waited for 2 hours. I think, and the CTG has started to become suspicious. So I should not wait for the CTG to become bad. There's no point in augmenting the labor with syntocinon. If you augment the labor at this point, I told you there is no push and pull concept. And if you augment the labor, the CTG may become more worse. So the best treatment for this patient will be going for emergency cesarean section. So option A is the best answer we have. Okay. So here the answer is option A. Advise emergency cesarean section. Let us see one next question. Again, this I expect it to be, we don't speak about this much, but in your labor room you would have seen these so many cases of these patients. So I believe this is a very important topic. So आप labor room में क्या देखते हो या आप post op में क्या देखते हो, वो ज्यादातर questions में आ सकता है. For example, आपको previously एक question आया था paralytic ileus के बारे में. So when they have asked you about paralytic ileus, they can always ask you about dural puncture, and probably this might come as a question. So what type of headache is associated with dural puncture? So when you are doing epidural, either for epidural anesthesia or epidural analgesia, we give epidural analgesia for painless labor. We give epidural analgesia for painless labor. So when you give epidural analgesia for painless labor, due to leak of some amount of the spinal fluid, the membranes cone. So due to leak of the some amount of spinal fluid, the membranes will start coning, and that will lead to the headache. That will lead to the headache. So what type of headache you will see in dural puncture, and how many of you have ever seen such patients in your hospital, guys? Very good, Ganesh. Excellent. True and valid point you have put forward. How many of you have seen post-dural puncture headache in your hospitals? It's very common. So this type of headache will go from frontal bone to occipital location. So it is fronto-occipital location. It is fronto-occipital location, right? So what is the treatment? And this headache progresses more towards the day. Matlab by evening she'll have more headache. And when she's taking rest, she's sleeping, that spinal fluid will not come out. But when she's walking or when she's doing some work, when she's sitting for a long time, there's more chance of leak of spinal fluid. So as the day ends, like by evening or by night, she'll have more headache. And after rest, that headache little decreases. And common treatment which we give is we give them NSAIDs for headache, and we ask them to drink a lot of caffeine. And my personal experience, actually none of these are indicated medically, but we tell them to drink caffeine and pickles, because salt रहेगा ना, salt will pull the fluid inside करके, right? But what is proven to be beneficial really for this dural headache is, which is not controlled by NSAIDs, is blood patch. So when not controlled by NSAIDs, we give epidural blood patch. So we inject the blood into the epidural space, so that that blood will clot and prevent further leaking of the spinal fluid, and that usually gives them the relief. So but that is the last resort. Very good, Sahil. Excellent. I appreciate, because that means you have seen some cases. So we asked them to drink plenty of fluids, caffeine, and I told pickles and all. And we asked them not to use pillows and not to avoid much going around till that headache comes down. Okay. So most evidence-based proven beneficial treatment is epidural blood patch. Epidural blood patch. So dural puncture is fronto-occipital location. Dural puncture headache is fronto-occipital location. Next question, guys. A 58-year-old woman, post-menopausal for last 8 years, comes with history of spotting per vaginum. What is the most likely cause? A 58-year-old woman, post-menopausal for last 8 years, comes with history of spotting per vaginum. What is the most likely cause? So when you have bleeding in a woman after menopause, after 8 years, what do you call such cases as? This is called as post-menopausal bleeding. This is called as post-menopausal bleeding. Yes, this is called as post-menopausal bleeding. And which is the most common cause of post-menopausal bleeding, guys? So the most common cause of post-menopausal bleeding is, very good, Nasira, Sahil, Ganesh and Sai Rachna. Correct. Atrophic endometritis. Atrophic endometritis. So print these few points in your brain, what I'm going to tell now. Most common cause of PMB. Most common cause of PMB is atrophic endometritis. Most common cause of PMB. Most common cause of PMB is atrophic endometritis. So first thing which should strike your brain when somebody is having postmenopausal bleeding is not cancer, it is atrophic vaginitis or senile endometritis. Next, most common cancer causing PMB in India. What is the most common cancer causing PMB in India? Cancer cervix. Cancer cervix. Most common cancer causing PMB, postmenopausal bleeding in developed countries. In developed countries is CA endometrium. Every question which I am discussing today has a potential to come in your exam, guys. Every question which I am discussing today has a potential to come in your exam, and this is what the mixture of questions which you tend to get in your exam. You know, some easy, some difficult, a combination of clinical questions. This is how the pattern which you can expect in your exam. Okay. So most common cancer causing PMB in developed countries is CA endometrium. Most common cancer causing PMB in India is cancer cervix. Most common cause of PMB is atrophic endometritis or atrophic vaginitis. What is the first investigation which you will do when you have a patient with postmenopausal bleeding? This has been previously asked in AIMS also. So what is the first investigation which you will do in this patient when somebody come to you with postmenopausal bleeding? Yes, I am waiting for your answers. So the first investigation which you're going to do when you have a patient coming to you with postmenopausal bleeding is, excellent Kishore, Dashu and Sahil, it is transvaginal sonography. आपका first investigation होना चाहिए transvaginal sonography. So again here there is a one important again there are some important points here. So the first investigation which you should do is TVS, transvaginal sonography, and on transvaginal sonography in postmenopausal women, if endometrial thickness is more than or equal to 4 mm according to FIGO and according to American College of Obstetrics and Gynecology, it is more than or equal to, sorry, according to FIGO only it is more than or equal to 5 mm. So please see in your question whether there is a option of 4 या 5. ठीक है, दोनों साथ में तो नहीं रहेंगे, 4 या 5 देख लो क्या है. अगर 4 है तो आंसर go for 4. If there is a 5, go for 5, right? If endometrial thickness is more than 4 mm, then your investigation of choice will be Dr. Nasira, I have done one exclusive video on missing pills, and I've put it in the DBMCI channel. So please see that, and I try to make it as simple as possible, and I've put all the case scenarios कि कैसा कितना pills छूट गया तो क्या करना and all. ठीक है? मैंने वो वीडियो डाला है DBMCI में. So investigation of choice will be office endometrial biopsy. Office endometrial biopsy with endometrial papillae. Yes. So office endometrial biopsy with endometrial papillae. Now I have one more very important point here. Gold standard. Gold standard is hysteroscopic DNC. See, fractional curettage is outdated. Very recently, some student has also messaged me this question. Ki what will be the gold standard? Gold standard nowadays is hysteroscopic DNC, not fractional curettage. Fractional curettage is outdated. So whenever you are suspecting endometrial cancer or endometrial lesion, or you have a focal lesion inside with thickened endometrium, your gold standard directly goes for hysteroscopic dilatation and curettage. See inside and pick up the curettage. No more fractional curettage. So 3 points in your brain. Whenever you have a post-menopausal bleeding, your first investigation should go for TVS. If endometrial thickness is more than or equal to 4 mm, then you have to do office endometrial biopsy with endometrial papillae or Vabra aspirator. Whereas your gold standard is hysteroscopic DNC. No more fractional curettage. No more fractional curettage. Okay. Next question. Next question. A patient presents at 28 weeks of gestation with pain abdomen. A patient presents at 28 with pain abdomen since 3 hours associated with decreased fetal movements. USG shows the following. Fetal heart rate shows 90 beats per minute. What is the management? Okay, what do you think the image is showing you? What do you think the image is showing you? Very good, Ganesh. Your answer is correct. What is the image showing us? Very good. So you can see behind the placenta there is bleeding. Behind the placenta there is bleeding. So this is a abruption. This is abruption, right? What type of abruption is this? Is it a revealed abruption or a concealed abruption? So here below the placenta there is bleeding. Actually it is written also placenta and retroplacental hemorrhage. So sometimes in images you can have the labeling. Labeling will guide you towards your answer. So हमेशा image का थोड़ा देखो यहाँ वहाँ कुछ labeling किया हुआ है क्या करके, right? And history के साथ you will get more better correlation. So here there is a retroplacental hemorrhage. So this is an abruption. So what is the management which you do for a, and this is a concealed abruption. So it is a concealed abruption with fetal distress. So you're all correct in answering that. You have to go for immediate LSCS. So whenever you have an abruption, you will go for whenever you have an abruption, you will go for with fetal distress, you will go for immediate LSCS. There is no wait and watch in abruption. There is no wait and watch for abruption. Okay, now tell me one more point, guys. Mano, here the baby is dead. Same question. FHR recording shows 0 beats per minute. Bacha is dead. Now what should be the management? Same question. Bacha is dead. What should be the management? So Nasira, in the previous case, when I wrote fetal heart rate was showing 90 beats per minute, when there is a fetal distress, you have to go for LSCS. Okay, only abruption with fetal distress, it is LSCS. But when you have abruption with no fetal distress, yeah, abruption with dead baby, then you will go for induction of labor. So when you have a dead baby, you will go for. So here I see some of your the concepts are going wrong. So let me tell you one small thing here. So whenever you have abruption, you have to check for the fetal status. If fetus is alive, then and there is no fetal distress, as Nazira is told, uterus is in Josh to push the baby out. So just help her. So you can do induction of labor. But if there is fetal distress, if fetal distress is positive, then you have to go for LSCS. Manu, if fetus is dead, If fetus is dead, then you have to check the maternal status. If there is DIC, correct DIC. And then you have to go for induction of labor. So only when you are conducting LSCS, only when there is a fetal distress, you will conduct LSCS. Otherwise, you are always doing induction of labor. Only when there is fetal distress, you will go for LSCS. Otherwise, with abruption, you will go for induction of labor only. Okay. So here मैंने क्या बोला? पहले I have told that there is fetal distress. So when there was a fetal distress, what did I tell you? The management was immediate LSCS. But अगर मैं change करूँगी question को कि FHR is showing dead baby, then your answer should go for immediate induction of labor. Because for dead baby, why do you want to unnecessarily open the uterus and spoil the, make the uterus risk for next pregnancy? It's anyway dead bacha, so go for induction of labor. Okay, understood all of you? Yes, Alka. Partogram, a very good question asked by Alka. So for partogram, we go marking from start at 4 centimeters. Partogram starts at 4 centimeters dilatation. For IUD, for intrauterine death, is it mifepristone or misoprostol? For intrauterine death, we prefer misoprostol. You can always give mifepristone for priming of the cervix, followed by you can go with misoprostol. So you can give mifi and miso, or you can give only misoprostol also. Okay. So next is a direct question. And a simple question. The prerequisites for external cephalic version rotation of the head are all except. Yes, Sahil. So Sahil has a query here that can we wait on an intrauterine death for 10 days? Yes, you can wait for 10 days when you have an intrauterine death for spontaneous expulsion. That is for MCQ purpose. But normally we don't wait. It mentally affects the woman very bad. That's why we go for induction. So we have different methods. We go with misoprostol plus extra amniotic saline infusion, or you can go Mifi plus misoprostol, or you can use laminaria tent. Okay. So the prerequisites, so this is a single liner. You cannot afford to lose mark in these questions. What are the rank making questions are? Yeah, rank losing questions are such questions. If you lose mark in previous clinical question, many can lose mark there. So not an issue. But jab you have single liners like this, which most of the students will answer correct. If you lose mark, that's a dangerous. And if you're answering wrong for such questions, it means you have to revise more. So prerequisites for external cephalic version of the head are all except. So you should have well flexed head. Correct. If you have a stargazing breech, you'll directly go for cesarean section. Can you do ECV in twins? Nahi na. So you should have singleton pregnancy only. एक ही बच्चा होना चाहिए inside the uterus to do ECV. Membrane should be intact is also one of the very important prerequisite. Do you require adequate pelvis or do you require favorable shape of the pelvis? Good, excellent. Majority of you have answered this wrong. Indeed, to be frank, none of you have answered correct. See how single liners can be dangerous. How many of you didn't see the except? Yeah, I've been reading so many times except, except, except. Don't tell me that you didn't see except. So what is the answer finally? Now you tell me what is the answer. C is the answer. Very good, Robin. C is the answer. So there should be favorable shape of the pelvis is not a prerequisite. You should have adequate pelvis. That is a prerequisite. You should have adequate pelvis. That is the prerequisite. So coming to the prerequisites of external cephalic version, you should have intact membranes. Patient should not be in active labor. Liquor should be adequate. Fetal heart rate should be normal. No contraindications for vaginal delivery. Gestational age should be more than 36 weeks. So these are the prerequisites. Intact membranes, patient not in active labor, liquor adequate, FHR normal, no contraindication for vaginal delivery, gestational age should be more than 36 weeks. Okay. So no contraindications for vaginal delivery means there should be adequate pelvis. So in primary, we do ECV around 36 weeks to term. In multi, you do ECV from 37 weeks to term. 37 weeks to term. Success rate is only 50%. Success rate is only 50%. And if she's RH negative, you can give anti-D injection and then you do ECV. I should have asked you, know, can we do ECV in a patient who is RH negative? Can we do ECV in a patient who is RH negative? Yes, you can do ECV in RH negative patient after giving anti-D. After giving anti-D. And give subcutaneous terbutaline before you perform ECV because subcutaneous terbutaline will help in uterine relaxation. Okay, I repeat again, you can do ECV in RH negative women. This can be asked. So you can do ECV in RH negative women after giving 300 micrograms of anti-D IM injection. Okay, and you cannot do it in RH isoimmunization, but you can do in RH negative women. What is this which you are seeing here, and what is the capacity of the catheter which is used in the PPH? Capacity of this catheter which we use it in PPH. Yes, Prashant. So without anti-D, there will be the risk of RH isoimmunization with the ECV. Because there is a risk of feto-maternal hemorrhage. That's why priorly you give anti-D and then perform external cephalic version. Yes, this is the Bakri balloon. This is the Bakri balloon. And maximum amount of fluid or the capacity of the fluid which you can give in the Bakri balloon is 500 ml. 500 ml. What is the Desi Jugaad for Bakri balloon, guys? What is the Desi Jugaad we have for Bakri balloon? Bakri balloon is expensive. What is our Desi Jugaad for Bakri balloon? So in India, alternate to Bakri balloon, which is free of cost, easy to make, and easy to control the PPH is very good, Nishita. Condom tamponade. It's also called as Shivkar's pack. It's also called as Shivkar's pack. It's also called as Shivkar's pack. So Bakri balloon is a medical device invented by Dr. Yunus Bakri. It's a balloon of 24 French, 54 centimeters long, silicone catheter with a filling capacity of 500 ml. It is used for temporary control and reduction of postpartum hemorrhage. So I have a query here that can we do external cephalic version in antepartum hemorrhage? So antepartum hemorrhage means placenta previa and abruption. Placenta previa में बच्चे को गोल गोल घुमा के कोई यूज है नहीं ना, because anyway placenta previa, what will be the mode of delivery? What will be the mode of delivery in placenta previa? Placenta previa, you will be anyway going into cesarean section. So what is the fun of gol gol kumana of bacha? No fun, right? So antepartum hemorrhage with placenta previa, no role of external cephalic version. Similarly, in abruption also, when there is an ongoing bleeding, this ECV itself is a risk factor for antepartum hemorrhage, for abruption. So when already there is an abruption, don't do the drama of ECV. Okay, so you cannot do ECV when there is an antepartum hemorrhage. There are contraindication for ECV. Right. Next question. Covalar uterus is associated with postpartum hemorrhage. Blood seeps into the muscle layer of the uterus in concealed variety. So this is the assertion, this is the reason. You have to choose which is the best answer for this assertion and reason. You have to choose which is the best answer for assertion and reason here. नहीं ट्राई करेंगे इमरान. So what is covalar uterus? Covalar uterus is, so I have D, C, D. Very good. D is the appropriate answer. So covalar uterus is where blood seeps into the myometrium of the uterus in concealed variety of abruption. So covalar uterus is seen in concealed variety of abruption where blood seeps into the myometrium of the uterus. How does the bleeding stop after the placental separation? So which is that important layer of the uterus which stops the bleeding post separation of the placenta? So the important layer which stops the bleeding, post placental separation is oblique muscle layer. But here, as the blood has seeped into the myometrium, this oblique muscle layer is not able to act like living ligature, and that's why they tend to go into PPH. So covalar uterus is associated with PPH is an absolutely true statement. And why is it associated with PPH? Because blood seeps into the muscle layer of the uterus in the concealed variety and it prevents it from contracting. So both assertion and reason are true, and reason explains the assertion also. So that is why you all are correct that assertion and reason are true and both explain each other. Option D is the correct answer. Very good. Yes. So criss cross layer or the oblique layer यहाँ पे function नहीं हो पाता है because blood has seeped into the uterus. So this is the picture of the covillary uterus, guys. This is the picture of the covillary uterus. Yes, answer is D. Answer is D. So assertion and reason are true and both explain each other. है ना? So answer is D, not C. Next. Last exam they've asked Robson's classification. To be frank, Robson's classification, I frankly tell, never we have prepared for our exam. But bad luck they've asked. Let me tell you, when they ask such googly, no, you should never get afraid. अगर कोई क्वेश्चन का आंसर आपको नहीं पता है, समझ लो किसी को भी नहीं पता होगा. So it is all your luck, which is favored by the hard work which you have done. Probably you might answer it correct. Those who want to play a safe game, they will not attempt which they don't know, I think, right? So Robson's classification was a googly question which has come last exam. We are not expecting such googly questions again, but yes, Quintero staging is something which we go on speaking and has not been asked till now. So probably they can give such staging also. So that's why I kept one question on Quintero staging. A 32-year-old presents with 12 weeks of scan showing T sign. T sign is seen in which type of presentation? Okay, Nasira, I'll plan one more. See, guys, you can message me ki what is the most important things which you want to see. I'll try to do one more session where I'll try to put all the types of placenta images and all maneuvers at one place. So I'll try to do one more session where I can show you all types of placentas and all maneuvers. Okay. Very good. T sign is seen in monochorionic diamniotic placenta. T sign is seen in monochorionic diamniotic placenta. Whereas what is the sign which you observe in dichorionic diamniotic placenta? What is the sign which you see in dichorionic diamniotic placenta? So dichorionic diamniotic presentation, the sign which we observe is lambda sign or twin peak sign. Lambda sign or twin peak sign. And in monochorionic diamniotic, we have the T sign. Her current scan is showing 26 weeks. At 26 weeks shows frank ascites in one of the twin. Diagnosis of twin-to-twin transfusion was made at 22 weeks. Which stage of the Quintero does the patient belong? So I will tell you what is the Quintero staging. So Quintero staging is stage 1 Oli-Poly sequence. Oli-Poly sequence. And urine in the bladder of donor twin visible. Urine in bladder of donor twin visible. Stage 2 no urine in the bladder twin. No urine in bladder twin. In bladder of donor twin. In bladder of donor twin. Stage 3 is abnormal Doppler finding in one or the other twin. Stage 3 में Doppler findings have become abnormal. So in stage 3, abnormal Doppler findings in one or other twin. Stage 4 में hydrops in one or the other twin. Ascites or hydrops in one or either twin. Stage 5 में demise of the either fetus. So stage 1 में Oli-Poly sequence and the bladder of the donor twin में urine दिख रहा है. Stage 2 में urine is not visible in the bladder donor twin. Stage 3 में abnormal Doppler findings. Stage 3 में abnormal Doppler finding. Stage 4 में ascites or frank hydrops in either twins. Stage 5 में demise of the either fetus. So now you answer what should be the correct answer for this patient. Yes, Pankaj, there are many methods. There are many methods how we can give the radiotherapy in patients with CA cervix. So we have point A and point B pertaining to the radiotherapy in those patients who are pertaining to radiotherapy in those patients where we are giving Manchester technique. Okay, but yes, in CA cervix there is an update of screening method. So that update of screening method, I'll try to post a small video on it. So here there is hydrops in one or the other twin, so it is stage 4. Hydrops in one or the other twin, so it is stage 4. Okay. Multiple pregnancy, reduction of a multiple pregnancy is done at. So when you have higher order births, when you're giving, when you see if there are 5 babies inside the uterus or if there are 7 babies inside the uterus, then the outcome of no baby is good. So what we do is when we get higher order births, we try to reduce them to singleton or twins. And that is called as multiple pregnancy reduction. So when you're when you're reducing the number of babies to 1 or 2 babies, in order to improve the viability of the living babies inside the uterus, that is called as multiple pregnancy reduction. And this is done in the early trimester itself. So it is between 11 to 13 years. So you do it in 11 to 13 years. Okay. So selective reduction is reduction of a selected fetus. Reduction of a selected fetus or fetuses in a multichorionic multifetal gestation to enhance the surviving of the remaining fetus. So it is typically performed between 10 to 13 weeks of gestation. It is typically performed between 10 to 13 weeks of gestation. You also have one more terminology here, that is called selective termination. So selective termination is when you are reducing or when you are trying to kill only the abnormal baby. That is called selective termination. Like you have trap twin reverse arterial perfusion, where you have a normal donor twin and you have a abnormal baby, an amorphous mass. So when you are trying to kill that amorphous mass, that is called selective termination. So this you usually diagnose at second trimester. So that's why selective termination is done in second trimester. So multiple pregnancy, reduction of multiple pregnancy is done at 11 to 13 weeks. At 11 to 13 weeks. So that's for today, guys. I hope you all enjoyed the session and you have learned something from these MCQs. Any doubt? So how do we select it is ultrasound. Ultrasound way we find out which is an abnormal baby. And once we find out which is an abnormal baby, we give KCl, potassium chloride, or we clamp the cord of that abnormal baby. So selective termination is done around second trimester. Yeah, one last question before we end for today. A female at 37 weeks of gestation has mild labor pains for 10 hours. Cervix is persistently 1 centimeter dilated but not effaced, non-effaced. What will be the next appropriate management? What will be the next appropriate management? So here she is in which stage of labor? She's persistently 1 centimeter dilated means she's in first stage of labor, and that too she's in latent phase. So when she's in latent phase, she can remain in latent phase, probably these, so she's only 1 centimeters for last 10 hours and she's not at all progressed means she's a false labor pains. and she's in latent phase. So what should be your next appropriate management in this patient? You have to just give sedation and wait. You have to just give sedation and wait. Okay. Sure, Prashant, I'll try to do that. But as of now, I'm definitely promising you that I will do one image-based session where I'll cover all the placentas and where I'll cover the all maneuvers at one place and I'll post. And I'll also try to post one all high yielding points for FMG before your exam. Okay. So thank you guys. Thank you guys. All the best. Keep studying. Be calm. Most important now is being calm, then studying more and more. So try to maintain calm. Don't give up. That's the most important. Stick to your books. Even if you're studying or not studying, you stick to the books. After half an hour, you'll start studying. But stick to your books. Okay? Intracardiac potassium chloride will kill the fetus. Intracardiac potassium chloride will kill the fetus, Ganesh. Thank you so much, Ganesh. That's you being too humble. Thank you so much. So I hope you all have learned from this session. I'll try coming up more and more such sessions and where we can discuss more MCQs. And as requested, I'll try to post a video or I'll try to come up with a video where I'll do all images live. Okay. Thank you so much, guys. All the best. Keep studying. See you soon. Okay, Prashant. When is my next session? We'll very soon plan it and we'll post it, guys. Lakshmikant, you give potassium chloride because intracardiac potassium chloride can kill the baby. Intracardium potassium can cause arrhythmias, no? Potassium causes arrhythmias. So when you're directly giving into the heart, it will lead to arrhythmias and death of the baby. Thank you. Bye, guys.